Continue with chapter 31. For your reassessment, you definitely want to repeat to make sure your interventions are working like they're supposed to make sure that your patient hasn't developed any further issues. So every 5 minutes for an unstable patient, every 15 for a stable patient. Re-looking through your interventions because your trauma patients often have several different injuries. And so you want to make sure that you assess their overall condition, stabilize the ABCs, control any like serious bleeding. Um, if your patient has critical issues, you may not get through a secondary. You may end up securing them to a long backboard, starting to transport, and you may be treating your ABCs the whole time without actually getting through a full legitimate secondary exam. However, you do need to complete that head to toe to make sure that you don't miss anything and then go from there. Um, if the patient doesn't have any life-threatening injuries, you may end up taking some extra time at the scene to stabilize their condition. Make sure that you are removing clothing to look for fractures, dislocations, severe deformities, swelling, ecchymosis, etc. There's a reason that we call it trauma naked. Now, if somebody has an isolated fracture of their leg, you certainly don't need to cut all of their clothes off, but make sure that you're visualizing what's going on. For your emergency medical care, um, you're going to start out with your primary assessment with anything else. If needed, perform a secondary assessment. Always follow your standard precautions. Be alert for signs and symptoms of internal bleeding. For your splinting, it's either a flexible or rigid device that's used to protect an injured extremity and also helps it maintain position. Oftentimes we splint in a position of function. Unless the patient's life is in immediate danger, you can go ahead and splint fractures, dislocations, sprains before moving the patient because that's going to cause further pain, can cause greater injuries. So it's definitely a good idea. Otherwise, you could get some more damage to muscles, more damage to, nerves, more damage to blood vessels. Definitely not what you want to do. Even closed fractures can cause um, quite a bit of internal damage. Splinting also reduces pain for your patient. Um, so it's nice for them. There's several other issues that it can cause. You can restrict distal blood flow if you don't splint because that deformity could actually cut off blood flow. You could get paralysis of your extremities, excessive bleeding into the tissues. So, splinting is a good idea if you have the time to do that. General principles of splinting: remove any clothing so that you can actively and adequately inspect the extremity for any decap BTLS. You want to note their neurovascular status, so CMS before, for sure. Cover any wounds with a dry sterile dressing. Don't move the patient before splinting an extremity unless there's an immediate danger to you or the patient. In a suspected fracture of the shaft of any bone, be sure to stabilize the joint above and the joint below the fracture. You want to go ahead and pad all of your rigid splints so that you can prevent like that local pressure and discomfort to the patient that could actually make their situation worse. You want to maintain manual stabilization of the injured extremity so you can minimize movement. If the fracture is in a long bone and it's resulted in pretty severe deformity, you can use constant, gentle manual traction to align the limb so it can be splinted. If you get resistance when you're trying to move it, just splint it in its deformed position. Immobilize all of your spinal injuries in a neutral inline position on a backboard. And when in doubt, just go ahead and splint it. Even if you're not 100% sure that something is broken, err on the side of caution. Rigid splints are made from non-formable material. They're applied to the sides, front, and or back of the injured extremity to prevent motion. Oftentimes it takes 2 people to apply a rigid splint. There are 2 situations in which you splint the limb in a position of deformity. When the deformity is severe and there's no way you're going to be able to realign, oftentimes there's more than a couple of shards of bone, and so you're not going to be able to get it to align. And then if you encounter resistance or extreme pain when applying that traction, just leave it. A lot of your dislocations are just going to be splinted in place. We're not going to try and reduce those. Your formable splints, soft splint is a pre-contoured, either inflatable, clear plastic air type splint. We also use a lot of like pillows or SAM splints are a big one as well. They're relatively comfortable, provides uniform contact and pressure across everywhere. Used to stabilize injuries below the elbow or below the knee. Pillows work great on ankles. SAM splints, not great for long areas because there's just not a whole lot of stability to them, but for like a wrist where you can double it up, works really, really, really well. For air splints, in particular for formable, the zipper can stick, clog with dirt, or end up freezing, and so it may not be the best to use, particularly in cold weather. And significant changes in the weather or altitude, like if you end up flying the patient, can affect the pressure of the air in the splint itself. Make sure that you're covering all wounds. Make sure that you use standard precautions. There's several other kinds of splints, including the vacuum splint, structural aluminum malleable splint, that's what SAM stands for, a sling and swath, and pelvic binders for pelvic fractures. Traction splints, we play with these every lab day. So you end up applying inline traction on a body structure in the direction of its normal alignment. It's the most effective way to realign a fracture of the shaft of a long bone so that the limb can be splinted more effectively. The primary used to secure fractures of the shaft of the femur, but there are some other ones. In the field, we pretty much only utilize traction splints for femur fractures. In the field, your goals are to stabilize the fracture fragments to prevent excessive movement, to align the limb sufficiently to allow it to be placed in a splint, and then to avoid neurovascular compromise. There's a couple of instances in which you would not use a traction splint. Upper extremities, we're not going to use them. Injuries close to or involving the knee. Injuries of the pelvis, partial amputations or avulsions with bone separation, and then lower leg, foot, or ankle injuries. Proper application often takes 2 EMTs. You want to be sure to control any external bleeding. The amount of traction that's required varies, but it often doesn't exceed 15 pounds total. We want to use the least amount of force necessary. First, we're going to take manual traction. So you actually grab the injured limb firmly. You start pulling. And once you start pulling that manual traction, then you're not going to let it go until you actually have the wound fully, or the limb, fully splinted. You want to imagine where the uninjured limb would lie, how it would look, often going to be using the uninjured side as a guide. And then if the patient strongly resists the traction or if it causes more pain, go ahead and stop and splint the limb in the deformed position. For your pelvic binders, They're used to splint the bony pelvis to reduce hemorrhage from bone ends, venous disruption, and pain. They provide just temporarily stabilization until true definitive stabilization can be applied. Generally, your pelvic binders are made of light, soft material. They're easily applied by one person, but sometimes you do have to apply it with more than one person. The SAM pelvic binder that you see in the picture, you can apply it by yourself, but it works really well if you've got two people. So, what happens if we don't splint properly? Well, you get compression of nerves, tissues, and blood vessels, which can certainly cause long term injury, delay in transport of a patient with a life threatening injury, reduction of distal circulation, which then causes further compromise to the limb, aggravation of the injury, and then excessive injury to tissue, nerves, blood vessels, and other muscles as a result of excessive movement. Very few musculoskeletal injuries are going to require you to drive lights and sirens back to the hospital. Once you have applied a dressing and a splint, your limbs are pretty much going to be stable. A patient with a pulseless limb definitely needs to be given a higher priority because the chances of long-term complications are much higher. If your treatment facility is an hour or more away, a patient with a pulseless limb should be transported by helicopter or immediate ground as quickly as possible. We're not going to be playing around on scene with these. So, specific injuries. For clavicle or collarbone, this is one of the most commonly fractured bones in the body. It often occurs when children fall on an outstretched hand. Oftentimes, the patient will report pain in the shoulder, and oftentimes they end up holding the arm of the affected side across their body. You often get generally and point tenderness over the clavicle, and because the clavicle is subcutaneous, it's often that the skin will tent over the fractured fragment, so you can kind of see exactly where that's at. Fractures of the scapula or shoulder blade are much less frequent because the bone is pretty much well protected by tons of large muscles. They're almost always the direct result of a forceful blow to the back, often directly over the scapulas. You may want to provide supplemental oxygen because the pain in that area is going to make it hard for your patient to take a good breath. Um, You want to also be wary of possible chest injuries, not so much the scapula, but the underlying tissues and structures underneath of that. You also have the possibility of having an AC joint injury. That's your acromion-clavicular joint. This is the joint between the outer end of the clavicle and the acromion process of the scapula. This is super often separated during sports such as football or hockey. So when somebody says that they have separated their shoulder, that's where this AC has been injured. Oftentimes, you're just going to use a sling and swath. You have triangular bandage material, and you'll create a sling to help support the weight of the injured arm. That way, you're going to reduce the amount of gravity that's pulling on it. And then you use a swath to go around the chest, making sure that you don't restrict any sort of breathing, but then that kind of binds the arm to the chest wall to keep it from swinging free. You got to make sure that you leave the patient's fingers exposed so that you can continue to check CMS. And even though that this is a soft splint, quote unquote, it's still considered a splint. So you will still be checking for distal pulses. We'll go ahead and stop here.